This is a patient, 49 years old male patient, presenting to us with hemoftalmus and mild cataract. After 2 weeks of observing the patient and his hemoftalmus, which didn't improve at all, we decided to perform the surgery, a concurrent procedure, a vitrectomy and cataract extraction. We started first with phacoemulsification, which is done under the surgical microscope. But as you see, we don't have red reflex at all due to this dense hemoftalmus. Although we dyed the capsule, we didn't get too much improvement. Still, it was helpful a bit, and we managed to perform a correct, continuous anterior capsulotomy. Then we followed the standard technique for phacoemulsification using the Centurion machine and torsional ultrasound energy with a chop technique. It is quite a soft nucleus, so the surgery shouldn't pose too much problems, except the fact that we don't have red reflex at all. So we need to be very careful with all our maneuvers in the anterior chamber and in the bag. At a certain point, as you will see later, we used the external optic fiber at the limbus, which would help us in visualizing better the anterior capsule. Another option would have been to put from the beginning the sclerotomies and the trocars and insert this external optic fiber via one of the trocars to obtain a retroillumination. But because we perform this part of the surgery at the surgical microscope, it is less convenient, more complicated to do so. That's why we use this optic fiber only externally at the limbus. We can obtain a pretty good visualization of the capsular axis and of the bag. And we decided to implant the IOL, and if it will be the case at the end of the complete surgery, when we hopefully will have a red reflex, we can complete the irrigation aspiration if it will be the case, there will be some cortical remnants in the bag. Now we put the NGenuity system and we continue the second part of the surgery, the vitrectomy itself. We put the 3 trocars, 25 gauge, single-use trocars, and we are using the external optic fiber and the vitrectomy at 7,500 cut rate. As you see, the hemoftalmus is really very dense. We don't see almost nothing, only clotted blood, dark red, and some whitish tissue, fibrin from the partially resorbed clotted blood, but still visibility is really very poor. So that's why we need to be very careful in our movements. We prefer to do the technique stop and cut. So we cut a bit in the center, exactly in the front of the optic fiber, then we stop. We observe carefully the area around the tip of the vitrectomy, and only after we are sure that there are no vessels, so no retina there, we continue to cut. Stop, observe, and cut. We don't go too far from the optic fiber tip. We cut exactly in front of it, where we are sure that there are no vessels, so no retina. As a matter of fact, this patient has been referred to us with a diagnostic of retinal detachment. The visual acuity was only light perception, with difficulties in seeing the light superiorly. But the BScan was relevant more for hemoftalmus, not for retinal detachment. So we decided to wait to give to the patient medical treatment only. The patient has cardiac failure and he was under anti-coagulant. We stopped the anti-coagulant treatment, the blood thinners, and we observed the patient for 2 weeks, but it was no improvement at all in these 2 weeks. The visual acuity remained the same, very, very low, light perception. The BScan was the same, so we decided for the surgery. Upon the BScan, we were almost sure that there was not a retinal detachment there, but you cannot be 100% sure until you are inside. So that's why we need to be very careful when we perform this, the vitrectomy. Again, cut, stop, observe, and cut. Stop, observe, and cut. With small steps, very close to the tip of the optic fiber. At a certain point, we put a chandelier light because we want to observe better the periphery and to indent. The surgeon prefers to indent herself the periphery and to perform shaving as much as it's possible to eliminate as much as possible of the vitreous and of the blood, which really fills completely the posterior cavity of the eye. It is very important to take your time, not to hurry. It could be a longer surgery, indeed, but it's better to be longer and safer than vice versa. And before any cutting, first you need to observe the tissue, the place in front of the optic fiber. We are progressing in our cleaning of the vitreous cavity. Still, we don't see the retina, we don't see the optic nerve. We aspirate a bit, but not pulling too much, because you don't really know what you are pulling. So aspirate a bit, then cut. Stop, observe, aspirate, and cut. The surgery is performed under local anesthesia, parabulbar anesthesia. Now we can see a bit better the periphery. The surgeon is indenting herself the periphery to see better the vitreous shaving. And we can also see some white tissue lying on the retina, on the posterior pole. We aspirate it and then cut it with very slow movements. And we can also notice the optic nerve and some preretinal hemorrhage fallen on the posterior pole in front of the macula. Initially we try to aspirate it, but because the visualization is not 100% good, it's still a bit hazy, we will leave it there, and as you will see later, we will push that blood with backflush cannula. We continue the shaving and the aspiration of and cutting of the vitreous and the blood in the right side of the eye by own indentation under chandelier illuminating. Again, very carefully, step by step. But now that we managed to clarify a bit the vitreous cavity and to see the tissues in the vitreous cavity, it seems that the retina is completely attached. So there's no problem with, we don't have retinal detachment. And now with the back flush cannula, we push the blood from which was lying down on the posterior pole, and then gently aspirate it, far from the macular area. Now we can see better the optic nerve, the macular area, and we can also see, most probably, the temporal superior artery branch interrupted and very thin. So we can assume it is the hemoftalmus is due to the artery branch occlusion. We continue shaving the peripheral vitreous and blood. Now a final inspection of the posterior pole, of the retina, the macula, before we perform the fluid air exchange. The surgery is almost ready, and we will leave air in the eye cavity as a tamponade. 2 weeks after the surgery, the patient saw 0.4, so quite useful visual acuity, and the fundus exam confirmed our intraoperative diagnostic of arterial branch occlusion. But because the patient had quite a good visual acuity, we assume that ciliary artery is present in this case, luckily. The surgery is ready. We withdrawn the trocars. No suture seems to be needed. Diatomy for closing the conjunctiva. Some air went onto the conjunctiva. The next day will be gone. This is how the BScan looked before the surgery, and this is how it looked a few days after the surgery. The vitreous cavity looked much, much, much better. Thank you.